What's going on, everybody? Welcome back to the Core Consults RX podcast. Cole and myself, and of course, our producer, as LinkedIn says, our executive producer, AJ. He just gave himself all kinds of titles on LinkedIn. We are joined by our P4 colleague, Trevor. Trevor, what's up, man?
Good. How you doing, brother?
Living the dream here in podcast world.
That's right.
Trevor's on rotation with me, so like always, I suggested
Strongly suggested.
If you want to not see me again next month, you come on the show. No, I'm just kidding. No, he was. I gave him the option. He said he wanted to do it. So happy to have you, man.
Absolutely, good to be here.
So 4th year, you got what, 4 months left?
Yeah, May's the cutoff date, man.
How was that feeling?
It's feeling great.
Yeah,
like the light at the end of the tunnel is getting a lot larger.
What do you have left, rotation wise?
I've got a couple of AMCARs, kind of like what we're doing.
Is it doing diabetes or anticoag or anything in particular?
I think it's hypertension and diabetes mostly. Might do some anticoag like warfarin if they still prescribe that. I've got some AMCARs. Let's see what else. The last one I think I have is an acute care. That's like internal med on a floor in a hospital back in the upstate. So
well, that's good. At least you go out with a really easy one.
Yeah, it'll be fun.
I mean,
not
personally, I think I took my last month off.
I did too.
Maybe.
No, I definitely.
Of course, there was a reason. It was to study for the NAPLEX.
Yeah, well, and plus back then, I don't know if they still do this, but back then you could take the NAPLEX early. I think they stopped that.
It was like it would change year to year.
Okay.
And my year, no, they would not let you take it early.
So I took mine, I think, either April 30th or May 1st.
Really?
So then I got licensed already, and I'm like, well, I'm not going to graduation. That's a 5-hour graduation. That's preposterous.
Right.
And so then they were like, well, but you have to go. And I was like, yeah, this piece of paper here says I don't have to because I have to be at work. And so, yeah, skip graduation.
Nice.
I did not skip graduation, but I was one of the first ones to take it. I think second.
Yeah, it's good. There's a real gamble with that because while it could be cool.
I say that anybody in my class who could verify that I didn't do it second, I'm going to take that back because I don't know. But I was one of the earlier ones to do it.
I think you did.
I don't want them sitting there like, I was second. You were third or something.
Nobody bully Cole, please. That's very rude.
Also, speaking of bullying, if my voice sounds really low quality compared to theirs,
it's because
I have the lesser mic today.
We gave him the crappy mic today. We're in a transition period where we're getting rid of this garbage equipment that we had, and we're getting much better upgrades.
So really, I sound as crisp and clean as I always have.
Right.
We
just sound even more
better
crisp.
Than you
hopefully.
Ever have.
We haven't listened to this either, just like last episode, so it might sound crappy.
And did we actually even listen to verify?
Mm-hmm. Oh, I did. Of course, okay. Dude. I always go back and listen to every word.
The whole thing, so you can edit out anything that's a problem.
I edit all the ums. Just kidding, I'm doing any of that.
Take out any pauses.
I barely even hit the upload button.
I did used to listen at least to part of every episode, but that was a long time ago.
Yeah, I just get too mad at myself. I'm like, you moron.
I think I sound dumb.
Hey, why don't you say some more dumb stuff? People are really interested in what you have. That's what I just criticize myself the whole time.
Yeah, I can remember all the dumb stuff I say, so I definitely don't need to go back and hear it again.
Trevor, one time Cole said that something like 130 billion people died from the flu or something. It wasn't that.
That sounds accurate. Yeah.
Spanish flu. No, actually, it was the swine flu.
Yeah.
Because the Spanish flu did kill, I'm not going to say a number because I'm going to get that wrong too.
So we've not looked at that number.
But it was the swine flu that I overstated.
Yeah,
that's okay.
Next episode, he's like, okay, I may have said a somewhat false.
Just divide what I said by 100, and that's what actually happened.
By a logarithmic. All right, so today we're doing things a little bit different. Instead of having like a set, topic, if you will, disease state to cover, we are going to look at the ANTLER Trial, which is basically maintenance or discontinuation of antidepressants in primary care. So this was an article that was published in New England Journal of Medicine in September, and basically kind of gives us some more insights when we're thinking about if a patient has basically reached remission from their depression symptoms, they're no longer, on paper clinically depressed, they're no longer having symptoms, and do we need to continue their therapy, especially if they have a prior history of relapses, or can we go ahead and titrate them off and have them come off the medication? That's been kind of a debate.
I think this trial is important because in general, as far as how long we're going to treat somebody with their first bout of depression, might treat them for 8 months to a year. If they're in remission, we could look at tapering off. And then after they've relapsed twice, so maybe after they hit their third episode is usually when we think, okay, this person's going to be on these meds forever. Turns out there's not a whole lot of like long-term data on that. It's been short-term studies that seem like if you start to discontinue, then patients relapse and that sort of thing. So this is more of a longer-term trial, which it has its issues, but we'll talk through that. But it's specifically looking at patients who have had at least 2 depressive episodes. But the vast majority, I think about 95%, actually had 3 prior depressive episodes. And they're looking at discontinuing their antidepressant therapy if they are stable.
Yeah.
And what happens there. So I think it's important.
Yeah. So, and plus we also had a request on the website, which I think actually I haven't had a chance to look at it yet, but I think AJ revamped for us today. So thank you, AJ.
Attaboy.
I need to take a look at it.
Yeah, but we had a request on that asking for the when are you guys going to review the ANTLER trial? So I was like, now.
We're way
watch
behind.
this.
What's true, 3 months behind is way behind for us.
That is true.
That being said, somebody had to physically carry this from all the way across the pond to America, so I'm sure it took like 3 months. Right?
Oh my gosh. The Pony Express is...
So this was a UK trial in New England Journal of Medicine. Do we have a lot of listeners in the UK?
Yeah, we have about 1,000.
Okay, so I probably shouldn't make fun of people from the UK.
Yeah, so guys, if you're in the UK right now, know that Cole was making fun of you, not me.
The
guy with the crappy microphone was making fun.
I'm gonna apologize in advance.
Yeah, thank you. It's better now you've apologized. Now we can start to rebuild. So we'll tell you, we're going to talk through some background information. Use this as an opportunity to kind of like refresh on just some characteristics of some of our common SSRIs and maybe a couple other miscellaneous meds. But we'll kind of go into that, and I'm also going to touch on a couple serotonin receptors as well, just because Trevor and I have been looking at some of that stuff this month. So kind of touch on that briefly, and then we'll jump through this trial real quick. So I guess, SSRIs we're all very familiar with. Obviously, they're inhibiting the reuptake of serotonin into the presynaptic neuron, and that allows more serotonin in the system, and it also allows for serotonin to interact with other, postsynaptic receptors, and they can have all kinds of various effects as well as adverse effects on the patient, and really can potentially complicate things or make things better depending on comorbidities. But some of the real common ones are fluoxetine, sertraline, paroxetine, citalopram, S-citalopram, and then one that's used pretty much exclusively in OCD patients is the fluvoxamine, but it is still considered an SSRI. And you'll see that 3 of those were used in the ANTLER trial anyway, so that's why we are kind of touching through these. When it comes to the box warning that's associated with pretty much anything that's dealing with some sort of depression or anxiety or some other type of psychic condition, they typically have a box warning that talks about a potential increased risk of suicidal thinking or behavior, and that can be children, adolescents, adults. It's something that it's a hard kind of concept to get around, because obviously why would we want to give a medication to a depressed person that could potentially worsen the depression or cause suicidal ideation? It's not that. The problem is with that is if somebody were to start having suicidal ideation or especially behavior, it's hard to directly say that there was the medication that caused it or didn't cause it. And so because there's been some correlation and whatnot, they put that warning on there just to make sure that you're monitoring for worsening of symptoms, and hopefully the patient has a support system that is kind of keeping an eye on them.
Right. It's a chicken or egg thing. Did the medication cause it, or were they predisposed to suicidal ideation? But when you're messing with neurotransmitters,
for sure.
Possible, right?
Absolutely. And then, some common adverse effects, the things you typically will hear people complain about, the GI complaints. Sometimes you'll experience some dry mouth, maybe some weakness or even tremor. Sexual dysfunction is the biggest one I personally hear patients complain about. And then some agents like citalopram and S-citalopram specifically, you do have to be aware of the dosing, because if you go over the max dose, you can greatly increase the risk of QTc prolongation. Fluoxetine has a tendency to, in some patients, cause a little bit of insomnia, whereas paroxetine has kind of the opposite. It's the most thought to be the most sedating out of the SSRIs. It's also the one we like the least. I'm going to speak for the group on that. But, it was even funny because the ANTLER trial even was like, we didn't include Fluoxetine because it kind of sucks.
And another thing they didn't include was Lexapro. So you mentioned that it causes escitalopram. You mentioned it causes QTC prolongation, but it should be significantly less. Than citalopram, right? We'll talk about it when we get to the trial, but I thought that was interesting.
Cole cannot wait to get to this trial.
I'm just ready,
Cole, just settle down with your mic that we can't hear you on.
But along with Paxil, we considered the worst. Also the worst was sexual dysfunction.
Yeah.
And probably discontinuation syndrome next to maybe Fluvox, but it's only for Fluvoxamine, but it's really only for OCD. So of the ones we use, Paxil's probably the worst.
Yeah. Cole, you want to go through like some of the medications that can increase the risk of serotonin syndrome, at least in theory?
Yeah, so pretty much, so SSRIs, you're always going to hear serotonin syndrome as a concern. So what is serotonin syndrome? Basically, excess serotonin that can cause flu-like symptoms, ataxia, can be very dangerous. How common is it? Not very common. Any drug that increases serotonin, being used along with an SSRI, you'll see the warning for serotonin syndrome. In general, I personally don't think it's that much of a concern, especially if it's just a single drug. Once you hit the 3-drug realm, you probably want to be aware of it, but especially in patients who have a history of it would obviously be a concern. But it's something that's big, bad, and scary that you hear about a lot, but I just don't think is very common at all.
Yeah.
But yeah, any SNRI, trazodone, anything that affects serotonin. Tricyclics.
Even like triptans and dextromethorphan. You get some cough medicine. Yeah, and I would say the only one that I personally like you were saying, unless there's like multiple drugs on the patient's profile, the only one obviously catches my eye immediately, which you almost never run into nowadays, is the MEOIs. Obviously, that's going to be a much bigger washout period and all that. But other than that, I typically, like you say, Cole, kind of just... it's probably not.
Yeah, MAOIs, especially considering they're contraindicated with SSRIs, you have to have the washout period and all that stuff. Yes, those are the ones that would be more concerning.
So don't freak out if you see a major drug interaction with one of those. It's probably not that clinically relevant. Just kind of keep an eye on it.
I kind of think about QTC prolongation the same way a lot of the times, though we have a way to screen for it, and that's a baseline EKG, which is recommended with citalopram. And I would say any drug that prolongs the QTC with a patient who has a history of arrhythmia or something like that, good idea to get a baseline EKG, especially if they're older or increased risk for something like that. And if you have any concern, just get a baseline and you can see if they're already prolonged or what it is, and you can follow up on that.
Yeah, or if you just if you're getting CMP and some other electrolyte values and realize their magnesium is low, that also could put them at risk for torsades, obviously. So.
Which is the one that we're concerned about with the QTC.
So just some other kind of... things to be aware of with some of the agents in this class. So fluoxetine has, and it's really the active metabolite, which is norfluoxetine. It has pretty much the longest half-life out of any of the traditional SSRIs. So we think of the half-life being anywhere from 6 to 9 days. And so one of the concerns with stopping one of these medications, which is what the main focus of what we're going to be talking about is basically the relapse of depression, versus the potential for, these depression-like symptoms that can kind of occur if you stop the medication too early. So they call it, like Cole mentioned earlier, discontinuation syndrome. Fluoxetine is one that, at least in theory, I have a lot less concern about because it's such a long half-life that it's kind of got almost like this self-taper. It's not quite how the ANTLER trial was set up as far as just kind of stopping it. But I do know if I have a patient where I'm really worried about them coming to their follow-up appointment or something like that, then fluoxetine is the one I may try to push just because, the half-life is long enough so it gives us a little bit of a buffer.
Right. Non-adherence is not as much of an issue. It's like the warfarin of the depression. Right? Yeah. If you miss a couple doses of warfarin, you're still going to have some anticoagulation. Whereas with the DOACs,
be a real problem. Also, one thing I'll mention, just because I've learned this relatively recently within the last year, if you have a patient with depression and they also are having occasions of outbursts of anger, fluoxetine is the one that has some really good data associated with that. And I've actually seen this play out in clinic a few times now. It's got some specific binding properties that kind of help with that particular state. But depression plus anger outbursts. Fluoxetine might be your guy. Paroxetine, speaking of half-lives, its half-life's only 21 hours.
Yep.
So for most of us, there's 24 hours in a day. So for 3 of those days, you're already starting towards the process of having this, drug start to leave your system. So it's one of those things that it tends, if you look across the board, in certain meta-analyses and things like that, it tends to be the one that some people kind of question its true efficacy, especially compared to the other agents in that class. And so for me personally, I tend to not use that one unless patients fully stable on it ahead of time.
But it's a fast mover in almost every pharmacy.
It is.
Yeah, it is.
Yeah, so is atenolol.
Old and cheap.
Yeah.
But yeah, there's really, you could go through 3 better ones before you hit Paxil. So
Absolutely.
There's really no reason to use it.
And it also is a 2D6 inhibitor, so the drug-drug interactions, which fluoxetine is as well as 2C19.
Yeah.
But the drug-drug interactions are definitely something to consider, as well as the side effects and all that. So
it's less safe in pregnancy.
Yes.
If I had a patient who was struggling with depression and this is what worked for them, sure, I would use it.
yeah,
But
no, I'd be like, nope.
Yeah,
I stick to my guns.
You got to stay depressed.
I go, no, dude.
If it was the only thing that worked.
I have a podcast.
In general, especially just starting patients, there's no reason to start with that.
For sure. One of the other concerns too is, especially back in the day, was if a patient has cardiovascular disease, specifically if they've had some sort of acute coronary syndrome or an MI or what have you. We won't go into the mechanism of why this worry came about, but one of the concerns was that the patients being on an SSRI could increase the risk of like another cardiovascular event. So they did a study called SAD-HEART, where they took patients who had had a history of recent MI, who were also depressed. They put them on sertraline, and they did not see any increased risk of secondary MI or any other cardiovascular event. So if you are worried about that, sertraline seems to be the evidence-based option to go with.
I've heard frequently that it's also like so is that probably that's why it's preferred diabetes?
Yeah.
Okay. Did you say that?
No.
Okay. But
and I actually said yeah right now. It didn't even process what you said. I just answered a question like an idiot.
Probably the best way to do things.
Yeah, I was like, yeah, that's probably what they do.
No, I heard colloquially that it's like the drug of choice in diabetes, and I didn't have a great reason for that, but SAD-HEART makes the most sense. Because it has, none of them, I guess it was trying to say that none of them had that increased risk, but specifically they looked at sertraline.
Yeah. That's probably why.
I guess at least we have like specific data for it to say that it's not going to increase heart risk, cardiovascular risk. Am I making sense?
Yeah.
Or am I just being crazy?
Nah, it's that mic, dude. It's not your fault.
I know. I can't even hear what I'm saying.
Don't worry, guys. We're gonna get Cole's mic fixed. He's gonna be back in full action.
Have you ever talked in like? It sounds like I'm talking underwater. That's what it sounds like through my headphones.
Cole can hold his breath for a long time. Now we're gonna get your mic fixed, man. I'm sorry. I feel bad for you over there. I look over at the sad mic and I go, oh, it's gotta be terrible.
We got SAD-HEART. This is sad
mic, but MIC. And
that's happy mic in case you got the good mic.
Yeah. It's so good over here.
Crisp.
So the other thing that you may see, especially if you're the pharmacists who are like verifying prescriptions, like in a dispensing role, one interaction that you'll most likely run into is the decreased platelet aggregation interaction with, whether it's an SSRI and like an NSAID or other, meds that could, or especially antiplatelets that could potentially decrease that platelet aggregation process. So the reason for that is because platelets, remember, have they store certain mediators in their dense granule. So like they'll store ATP, free calcium, serotonin specifically, and those are all kind of helping to mediate the process of signaling involved with platelet aggregation. Well, platelets don't produce serotonin on their own. They have to get it from their environment. And so what happens is the serotonin receptor inhibitor, reuptake inhibitor, blocks that transporter on the platelet that's responsible for bringing in serotonin from the environment into the dense granule. Now, the thing is clinically, that's not super important. You'd have to have a pretty high bleed risk before we'd start really worrying about that. But it always comes up as either a moderate, if not a major interaction, and can, especially if you're just now getting into the game of, being a pharmacist and whatnot, you might see that and go, huh.
If you haven't gotten used to just ignoring all interaction pop-ups.
I can't remember the last time I even looked at it. I'm just kidding. That's false. I don't work in dispensing pharmacies. That's why I can joke like that.
Even in non-dispensing,
I would be fired immediately.
They still pop up a lot. But yes, I need to pay closer attention.
I fly right through it, especially on e-clam. Like, no, this is a pharmacist's job.
But the pharmacist is like, oh, this is the clinic's job.
And then nobody catches it. So
terrible.
Yeah, it's pretty bad. So the last couple meds, I don't know if Cole, if you want to take these or whatever, but I will say this little quick story. So when I was first teaching at the PA school, I was kind of coming up with these slides, and when vilazodone or Vibrant, and then vortioxetine or Trintellix were kind of first getting talked about. I needed a way to kind of differentiate them because they are SSRIs, but they also have some kind of other activity. Like for example, vilazodone is a partial agonist at 5-HT1A, which we'll talk a little bit more in detail in a minute. But if you are trying to help a patient with depression, you want to have agonist activity at 5-HT1A, and then antagonism at 5-HT2A. So that's the ticket. Anyways, I was like trying to figure out how I could differentiate this, and I was like, oh, SSRI plus, I'll make up a thing. I told my students I made that up. So one of my PA students, who I won't say his name because I like him a lot, he's obviously been a PA for a while now, goes on his psych rotation and says, oh, that's an SSRI plus. And the psych doctor was like, what?
Who taught you that?
Yeah, and he goes, oh, my pharm professor said that everyone calls him that. And I said, his name's Mike. He tells him like my name. I'm like, dude, first of all, I never said anything about any of that. I was like, okay, that's it. Failed. I'm going in there to change this grade.
You're going to retroactively fail him because
I went back and said,
already passed.
I actually went back and I actually recalculated your grade. It turns out you got a big fat F.
You called the what is it, the bursar's office, the bursar.
Yeah,
I've been corrected many times. And I can't recall how to say it. And changed it on his transcript.
Yeah, I did. I said I got $20 right here that says you do an inside job for me.
Yeah, you just need an asterisk above the plus sign,
right?
And then at the bottom of the slide it says
not real.
Yeah.
Listen to the words coming out of my face when I talk.
Mike's vernacular.
Yeah.
See trash in previous slides.
Yeah, exactly. Yeah. Thank you, Cole. So you get it.
Yes. So Vibrant. So yeah, like you said, SSRI plus 5-HT1A partial agonist. So it does have a box warning for increased suicidal thinking like all the rest of them. But otherwise, it's pretty much going to be tolerated the same way as far as having stomach upset and possible sexual dysfunctions and that sort of thing. But Trintellix, vortioxetine, previously Brintellix, they decided to confuse everybody by switching.
Yeah, thanks Brintilla.
What do you think that was? Marketing?
Because of Brintilla. They were worried about getting interactions. Not Brintilla. I'm an idiot. Berlinta.
The antiplatelet.
Yeah.
Right.
So they were worried about those getting confused. They changed the name.
Look like, sound alike?
Yeah.
Wow.
Mm-hmm. Okay. I remember this doctor that came in, physician, came into the pharmacy when that first happened. He was like, why'd they change the name of the med? I said, I think they were worried about, you could tell this guy was just in a stellar mood. He's just still in his scrubs. He's totally irritated about whatever happened in his day. And I said, they're worried about lookalike, sign alike, blah, blah, blah. And he goes, I mean, how stupid can pharmacy be? I was like, oh, man, thank you.
Have a good day, sir.
Yeah, I hope the rest of your day goes super swell.
That is very interesting.
Yeah, he's very angry.
I did not know that.
About that guy or the...
Yeah, I know that guy.
Yeah, don't hang out with him.
I mean, I'm thinking they're different companies, right?
What?
Like the makers are.
No, I don't think. Those two drugs?
But between Trintellix.
I actually don't know.
Say if they're different, which obviously this could be easily looked up, but I'm not going to right now.
If only we had a website.
I mean, that has to cost a lot of money to rebrand.
Easy.
I mean, I get that it's only one letter, and really all you have to do is shave off a little portion of the B on the bottom.
But, it's true.
And then, add a little bit on the top. But even still, that's got to be a lot of cash. I'd want to sue,
Man, maybe.
That marketing department just went into panic mode when they saw that.
Yeah. They said we had to totally rebrand, change all our labels.
Mm-hmm. Now, instead of Brintellix, we're going to be known as, wait for it, Trintellix. People are like, genius.
I wonder if that's ever happened before, that brand name is just
I'm sure.
Really?
I mean,
I've never heard of it.
I mean, I haven't either, but in the history of medicine, probably.
Well,
maybe.
Anyways, it's the same.
We spent 10 minutes on this.
It works the same way, but it does have an interaction with 2D6. So if you're giving it with a strong 2D6 inhibitor, reduce the dose, but otherwise, it's just adding on a little bit of 5-HT1A activity to help it out a little bit.
And I will say, too, as far as the adverse effects, so there is still obviously the risk of sexual dysfunction. However, there was a study from 2016 that compared escitalopram to vortioxetine, and vortioxetine had less instances of sexual dysfunction. And at that point, Lexapro was kind of considered to be one of the better options to avoid that anyway. Yeah. And so I have that's one thing I've used vortioxetine for at the clinic was patients who were doing well on an SSRI, but the sexual dysfunction was just becoming a real issue. And so switching to vortioxetine, I've been involved with that 3 times, and 2 of them, the sexual dysfunction went away. One of them, guy's like, still problem. He's so mad. I was like, okay, 2 for 3, not bad.
Wellbutrin for you.
Yeah, exactly. That's exactly what he got. All right. So we'll kind of jump into some of these receptors real quick, just to touch on them, and we'll get to this trial. But we mentioned 5-HT1A. So when you're thinking about, what we would want to cause, activity at, or we would want to block or be an antagonist at when it comes to depression specifically. Remember, 5-HT1A is where we would want to have agonist activity that can basically help with mood and anxiety and all that. And then with 5-HT2A, that is where you're going to want to have antagonism, because that can basically be involved with almost like certain aspects of like psychosis and things like that. So like, for example, 5-HT2A, for certain like psychedelics like LSD or something like that, they can actually activate it. They work as an agonist at that particular serotonin receptor, and that's where some of like the psychoactive effects can sort of come from. There's obviously other factors at play, but that's one aspect of it. So when we're treating depression, we actually go the other way, where we're looking at having what they would refer to as like a silent antagonist, or even an inverse agonist. And that's basically like not just stopping the process of experiencing that activity at 5-HT2A, but also just doing the opposite in effect physiologically. And then so the other kind of important 5-HT receptors to think about, 5-HT3 is the one we think about when it comes to like vomiting or nausea. So it's like when we give Zofran, that's what it's blocking. And so there's certain medications that can kind of help in that regard. So vortioxetine is one of them. And so you get some antagonist activity with vortioxetine. So if the patient's having GI issues with some of the other SSRIs, that could potentially be something you can switch to hopefully mitigate some of those. And then one of the interesting kind of things to think about, in my opinion anyway, because I'm a dork, is the 5-HT2C. Trevor, what are we thinking about with 5-HT2C, since you've heard me say it 1,000 times this month?
GI upset.
And what else? Feelings of
hunger and wanting to eat everything in the room.
So if you've ever dealt with someone who has been on mirtazapine, most likely you've seen that it greatly increases the appetite. And that's because you get this basically blocking of the 5-HT2C, which is when you block that, you actually block your ability, or at least one of your chemical pathways to kind of alleviate your hunger or feeling of hunger. So you block that, you just kind of stay in that feeling of needing to eat, feeling hungry. Actually, fluoxetine also has some of that effect. So that's why if you look at the comparison of adverse effects of some of the SSRIs, fluoxetine does tend to have a little bit more risk of things like weight gain and whatnot. And I'll actually use that as a segue into promoting our sponsor for this episode, which is our buddy that you've heard of before, Pearls. It's a great drug info app. Pearls, it's spelled PYRLS, and it's written by a PharmD who also is a fantastic coder, which is a skill set I could only dream of doing. And he's doing fantastic work. Pearls is definitely getting more and more content each month, and there are over 400 drugs involved now, and he has all kinds of fantastic charts and things like that, including certain antidepressant adverse effect comparison charts. So they have one on drowsiness and weight gain and a few others. So if you go to www.pearls.com/coreconsultrx, you can sign up for a free it's like a free membership with your email address, and then if something's not for you, you can always cancel it, but you'll get access to a bunch of free charts and some of the other things that he's created just to kind of try it out. If you don't like it, you don't have to keep going, but it's, we're very grateful to have the support of Pearls, and he's kind of our first big official sponsor that we've had, and so we greatly appreciate everything Derek's done for us, and definitely check his app out. It's definitely worth the time. So anyways, back to our regular scheduled program.
Perfect segue.
Yeah, you see that? It just came to me.
Into the trial. I can't see how long we've been recording anymore because of the way the screen is set up, so I just have to presume that this is a good time to get into the trial.
Yeah. One more thing about receptors, because I know you guys are just dying to hear about receptors.
Love them.
5-HT7. That's one that you don't really hear too much about. And also, you can get some antagonism activity with vortioxetine, which then can help with depression symptoms and anxiety and feelings of fear, things like that. So that's another kind of caveat that you have with vortioxetine. Sounds like I'm really pushing this drug, even though we're not really talking about it. But
do they sponsor you?
I wish. Yeah,
we'll talk about it more, though.
Yeah, for sure. Actually, because I do actually like that one. But that 5-HT7 is activities kind of where they're thinking maybe some of the added benefit potentially comes from. So yeah, just want to make sure I mention that. And make sure if you are thinking that all SSRIs are created equal and that the boring medchem or pharmchem stuff is just not important because you're going to be a pharmacist, dude, just have a better attitude, okay? Yeah. Please. Look it up on Wikipedia if you have to.
Start grinding.
Yeah. Thank you, Trevor.
You're welcome.
All right. Unfailed.
Yes.
We'll see how you do tomorrow.
That's what I'm talking about.
Yeah. You're going to do great things, man. All right. Let's talk about this trial.
Yes. So I talked a little bit earlier about what it was, but there's one thing I want to point out at the beginning. The name of the trial is Maintenance or Discontinuation of Antidepressants in Primary Care. That's what it got in New England Journal of Medicine. But it's called the ANTLER Trial because it's the antidepressants to prevent relapse and depression. Mm-hmm. So basically what this is saying is regardless of the title of our trial, when we make a randomized clinical trial, we can use an acronym to be whatever we want. We just have to come up with a little phrase that goes with it. Doesn't have to be the name of the trial.
Right. Oh, it's going to be the Core Consult RX trial, and it's going to be like Indapamide versus HTZ.
Yeah.
That's it. I mean, what does it stand for? Trevor. Okay, I failed again.
I thought that the acronym had to be loosely based on the title, but no.
Extremely loosely based. They both have the word antidepressant.
They do both have that word.
Cool. You're very negative today. I don't like it.
Well,
I will say they didn't teach us that in school.
No,
not at all.
Yeah.
You only get this from the CCRX podcast.
So much gold.
Anyways, so yes, this again to reorient you back to the beginning of the podcast when we referenced this. This trial is looking at patients who are stable. They've had multiple depressive episodes in the past, multiple relapses in the past. They're stable on their antidepressive. And we want to see if discontinuing them is going to increase their risk for relapse. So I'm going to give the results first, and then we're going to talk about whether we can trust this trial or not, and that'll be your cliffhanger. But the results effectively were the patients who discontinued the antidepressant had a twofold higher risk of a relapse. So just before we get into the meat of it, that sounds like it would support not discontinuing and continuing therapy. So let's talk about it. There were 478 patients in this trial. It was all done with primary care patients. So not a neurologist, it was done with primary care. And to me, that was kind of a small number. I mean, I guess it's not bad considering we don't have too many trials like this, but I'm looking a little deeper. They actually screened over 30,000 patients, a huge number of patients over the course of a long period of time. And it's actually kind of unclear as to what that period was. It seems like it was sometime in the 2010s, so sometime in the last decade. So there were over 30,500 pre-screened. 23,000 of those patients were actually invited to participate. So they said the 23,000 met the criteria that we'll talk about to participate in this trial. Only 1,300 of those actually said they were interested in participating, and then the final number was 478.
Yeah,
that's interesting.
It's very strange. Well, I'm wondering, and we probably can find this information like the supplemental data. We just hadn't glanced at that part yet. But my guess, not my guess, but my question would be how did you go about screening? Did you cold call these people, and they just thought you were selling DirecTV or something, and they were like, no, and they just hung up on him.
My guess is the screen was done with the questionnaires.
Yeah, I mean, that's what I would think.
But
right, how in the world with that many people?
Well, it's because they probably gave this as more of a standard of practice for patients with depression. They gave the questionnaires, which we'll talk about.
Yeah.
And then 30,000 of those patients completed the questionnaires, and then based on chart reviews, they were able to establish that, these patients completed questionnaires have had this many relapses. So based on that, they might qualify. Let's invite them, and then we can tease out whether they actually qualify or not. So I think that's probably kind of how it went. But that is just me speculating. I didn't look.
Sounds like, God, Cole, you're supposed to always look. It definitely sounds like they're cherry picking. That's all I'm going to say. AJ, what do you think?
It's a little sketchy.
Yeah, thank you, AJ.
Very.
It's a critique. It doesn't mean that the data is not good, but it's a critique. So what happened was the trial. The patients were either continued on their maintenance antidepressant. We'll talk about which ones those were. Or they were tapered off of their antidepressant completely and continued on placebo. So it was blinded. They didn't know if they were taking their regular drug or if they had come off placebo. It's also important to note that all these patients would have had to agree that they were okay with coming off of placebo, coming off of their drug. So I'm sure there were a lot of patients who were like, no, I don't want to.
Yeah.
And so at baseline, these patients were okay with the idea of not being on their medication anymore. So I think that means something to take into account, especially with a depression trial, where placebo effect is big.
That's a hard sell. Hey, you remember how multiple times in your life we've taken you off this medicine and you felt horrible again?
Right.
We're going to try it again,
So
but this time it's for science.
It was the people who were okay with doing that were on this. So they actually continued this for 52 weeks. So they either continued their maintenance drug for a year or they were on the placebo for a year once they came off their maintenance drug. So it was actually a pretty long time as far as these things go, which is good. I think a year is kind of what we're looking for here. It was the generalizability. That's one critique because of the low number of patients. And there were still some patients who weren't able to complete the entire study drug because they ran out of I think it was sertraline.
Yeah,
it was.
They just didn't have enough of it. I'm so confused as to how this could happen, that they didn't just have enough and that they could give them and continue. So there's a segment of patients, and I'll get to the number in a second, but there's a segment of patients who only got 8 to 11 months of the study drug and didn't make the full 52 weeks.
It's very strange. There's got to be a better explanation to that.
There has to be.
Did you see anything about that, Trevor, when you were looking at it?
Yeah, I actually did in the supplemental data.
I knew it was in there.
They break it down for
That's
you.
why I had Trevor look at it instead of me.
But they basically, they intended the 12 months, but due to a, quote, limited supply, one patient received 11 months, and then 18 patients received 10 months, and then finally 2 received 8 months of the medications. And they claim in the supplemental data that the events did not differ by the randomized groups. So they claim that these differences in the supply didn't really affect their overall data.
I just can't imagine why you would. It was Zoloft, right?
Yes.
I just can't imagine why you would run out of Zoloft, first of all. But also, if you are funding a trial on depression where this is one of the 4 drugs that you're looking at, that you would run out of Zoloft.
They're like, we should have done 3 drugs. I knew 4 was going to be too many.
I'm just baffled.
Yeah.
Anyways.
But I think, did they not have the $4 list over in the UK?
Did they not have $4
It's
list
so
in the UK?
easy to get sertraline here.
Well, probably it's free.
Yeah. Oh, yeah, that's right. You guys have way better healthcare. Never mind.
Different health.
Sorry, as you were.
But yeah, so they looked at Zoloft was one of the study drugs. Citalopram was one of the study drugs. Fluoxetine was one of the study drugs, and mirtazapine. So they specifically, so there were some that they intentionally did not use. Mm-hmm. So we talked earlier about paroxetine. Makes sense. Don't like paroxetine. Concern for withdrawal syndromes and that affecting their data. They didn't want to use venlafaxine because of concern for withdrawal symptoms. We didn't talk too much about SSRIs, but they can have kind of tough discontinuation syndrome. But also because it's not really considered first line like the SSRIs are. That's fine. But then an exclusion criteria was the use of escitalopram. And I'm seeing that because it's not a common drug in the UK.
How?
And so I've got 2 questions. One, why is it not a common drug in the UK?
Right.
Because the government, I'm assuming it's probably more expensive, right?
A formulary thing?
Yeah, probably.
If I'm choosing between citalopram and escitalopram, I'm not sure why I wouldn't go with escitalopram first from a QTC perspective, right? Unless there's something I'm missing with efficacy.
I would imagine it's got to be a funding thing.
Yeah.
Because escitalopram, I would think, is more expensive. That may be an extremely ignorant point of view, but
I know that they are both cheap here.
Thank you, Trevor.
Within a few dollars for a month's supply, but I guess yes. I don't know.
Yeah.
I don't know what it is.
But how much does your depression cost? We talking pennies here for getting somebody a better medication. Obviously better medication.
Even still, whether or not it was ubiquitous in the UK, I'm just surprised that they would exclude it from the trial.
Yeah,
Right.
It's interesting.
So yeah, that's one exclusion criteria. Other exclusion criteria are obviously if they are currently depressed, because these are all supposed to be stable patients. If they had other kind of bipolar type disorders, which you wouldn't really want to be using SSRIs for anyway for depression in those. If they were on an MAOI, and women who were pregnant or looking to become pregnant.
Nicole said that this was blinded. What they did is they took these basically these lactose film coated over encapsulated capsules, and they kind of hid the medication in these capsules so that everybody looked like they were taking the same thing. That's how they blinded it. And then also the capsules were all identical in appearance, as well as the bottles that they were provided in. So the clinicians also were blinded. The titration schedules, as they were trying to wean these patients off. So if they were in the citalopram, sertraline, or mirtazapine discontinuation group, for the first month, you would receive the medication that you had been stable on at half of the regular dose for the whole month. Starting month 2, you'd receive half dose antidepressant, and then every other day you get placebo. So it's alternating days, half dose antidepressant, placebo, alternating. Third month, receive placebo only. So by month 3, you're weaned off officially. It's just the other group that was still on the medication, they had to continue taking the placebo so they could keep it blinded. Fluoxetine, they did a little differently. So because of the long half-life, the discontinuation group, the first month basically received 20 milligrams of fluoxetine and then the placebo on alternating days. And they did that right off the bat from the first month. By month 2, received placebo only. So it was a much quicker time period to get them off, or by much quicker I mean exactly 1 month, and to get them off of the medication. So that they did it a little bit differently because of the half-life. So throw that out there.
Another thing crazy with the fluoxetine, just like supply chain, the 10 milligram capsules weren't available at the time of the enrollment. So the 20 milligrams and the placebos were on alternating days, and they weren't able to actually go down to the 10. And just kind of begs the question, if you know you're going to do the trial, why do you not have a way to get a 10 milligram tablet or capsule for...
Baffled.
I'm wondering if by the time this is also probably a stupid comment, but I'm wondering by the time they actually really got into the thick of the study, if that's right when COVID started happening, everything got shut down.
Might.
It's very possible.
Maybe.
Might.
So one of our UK listeners, please educate us on what
possible,
happened.
Because this was released September 2021, probably occurred around 2019. Very well could have been something like that.
Yeah, so if you listen in the UK, we've got several of them, so please educate us. And email AJ. He'll get right back to you. He's our executive producer.
Some other kind of baseline things. One critique is that it wasn't a very diverse study. 71% were female, 93% Caucasian. The scores that they used, which this isn't a critique, I'm just letting you know the scores that they used to kind of measure the depression, but also anxiety, were the PHQ-9, which I think is good, very, very commonly used. We're all familiar with the PHQ-2, where you'll ask if somebody has, little or no interest in doing things, or if they're feeling down or hopeless or depressed. There's also the GAD-7 that they used, which was more specific for anxiety. It's the general anxiety disorder score 7. And so they had kind of baseline scores that people were tested on, and throughout the trial they reassessed.
Yeah. And that's where this can get really sticky. If you look at it from the overview, and you're just talking about depression, looking at the discontinuations, that's one thing. But when you consider patients who probably had some comorbid anxiety, which is very, very common, and we saw when STAR-D, very popular, well-known study, when the patient had depression as well as some anxious distress on top of that, it made reaching remission much more difficult. So I'd imagine the same thing would be very likely with relapses as well. So
I would imagine too. And also, these scores are just, scores. They're basing all the data on these 2 rating scales, and that's tough. So basically, we didn't get into the specifics of the outcomes, but 39% of the placebo group or the maintenance group had a depression relapse. 56% of the placebo group had a maintenance relapse. So they determined that was a number needed to harm of 6 for trying to taper somebody off of their antidepressant when they're stable after they've had more than 2 relapses.
Mm-hmm.
So that's compelling. Holes that you can poke in it, but I mean, number need to harm 6 is compelling.
Yeah. So I mean, and it's one of those things. I feel like, I mean, if it was me personally, and I was, getting at it, and I've never been in a situation. I'm just obviously speaking hypothetically, but if I were, had multiple relapses and I was feeling good, I was feeling stable, I wasn't having the same symptoms, I feel like it would be, unless I was just having significant quality of life, disruptions because of the medication, I would feel like I would not want to come off of it.
No, I wouldn't either. But at the same time, when while this is a good data to have, it's probably a little bit disheartening for patients because anytime you're starting on a new medication, the obvious question is, how long do I need to take this medication? So throughout the first couple of years, you can say, well, we're going to give it to you. We're going to give it a good try. If you're doing well, we can take you off. But after a couple times, I mean, this is just additional data to say you're going to have to be on this forever. And nobody likes hearing that. Regardless, of, I mean, I'm sure they're like, I don't want to be depressed. I'm going to keep taking this medicine. But nobody wants to have a medication to hold.
So AJ sent me AJ's great having you back there, dude. AJ sent me a paper that is talking about the National Institute of Health and Care Excellence, the NICE guidelines from the UK, and talking about the preferred antidepressants for treating general depression disorder. And they basically quote a Cochrane review that concluded that escitalopram seems to be less effective than citalopram, which it's a 2012 article. I'm not familiar with that one myself, but it says that they also looked at the cost effectiveness of the treatment. So cost of the drug versus treatment benefit. In this case, citalopram and sertraline are cheaper options for the treatment of depression, and it would be cheaper to buy citalopram and sertraline for the treatment of depression. It was the NICE guidelines 2015.
So they're taking it from a efficacy and cost perspective.
And
I mean,
okay. I wasn't totally off base, I guess. Cool.
Yeah. I mean, I would definitely say here now. So I guess that was a long time ago. Here now, it's definitely affordable. I mean, it's as affordable as the others, I would say.
Yep.
To us, within a margin of error difference.
Anything else with the study or anything that we need to talk about?
That's the big thing. I think it's important to remind people that the placebo, usually you're looking for, usually when we're looking at in depression studies and we're looking at depression meds, we're looking at how effective is it when you're getting somebody on something. So this is a little bit different, but I think it's always important to note that the placebo effect can be very strong one way or the other. In this case, for, the negative, right? So these patients were stable. They continued on their maintenance therapy, and there was still a 39% relapse rate with the maintenance drug.
Yeah, absolutely.
Thinking that they might have come off of their drug, right? So that was almost a placebo effect to the opposite.
Nocebo.
It's nocebo effect, I suppose. So
that is interesting.
It plays an important role in depression. It's definitely something that needs to be considered.
Absolutely. And, and I think Cole mentioned this too, but just to kind of reiterate too, when you look at the doses that they were using, it's almost like half doses for what we typically would push them to. Sertraline 200 milligrams would be the goal dose if they can tolerate it. So it also could be that they were on not effective doses. They thought their symptoms were in remission, but maybe it was just kind of like just enough to keep them, as far as their PHQ-9 or whatever their rating system was, just enough to keep them in remission. But maybe we should have pushed it a little harder for a little bit longer, and then maybe have better results coming off of it. Who knows? But that's why they say that this the generalizability of this study is kind of limited to the general population.
You might have mentioned it with the methods, but did they adjust their doses to keep them on a maintenance dose that was specific to what they wanted, or did they?
I think they started, it was like with Fluoxetine, they were on, the 20 milligrams was the starting dose.
Yeah, they continued their maintenance dose if they were in the arm of continuing.
So they, no matter what, continued their maintenance dose, and they still only ended up with 4 drugs with the exact same doses.
I think that's why they had such a hard time. Another reason why they had such a hard time enrolling patients, because I think they were they wanted all the citalopram to be 20 milligrams so they could all be compared.
So interesting.
Not
So
40 for one and 20.
Which they didn't include that in exclusion criteria, but I guess they had to cut anyone who wasn't on those doses, even if they met all other criteria.
Because that's why it says taking this daily dose.
It's unusual.
Yeah, it's a very strange study.
Yeah.
I mean, I'm not super surprised by the results by any stretch of the imagination.
No.
But,
I mean, this fits in with what we've been taught and teaching and things like that.
Yeah, right. And I definitely would be curious to see this done again with maybe a little bit different methods.
Yeah.
But I also have no idea what I'm talking about. So there's also that. What else, boys? Anything?
Not to be a Debbie Downer, but I think it's crazy how we're comparing the maintenance group and we still have a 40% relapse rate. It just kind of shows this, depression and anxiety and stuff is still so, not completely understood, that we're doing these trials and finding that even though we continue these medications for patients, 40% of them are still going to have some kind of relapse and depression. It's pretty interesting.
And that's an even higher rate than somebody who if for somebody who met remission at that point and had been stable for however long they had, I can't remember how long it was, maybe a year. That's still a bit higher rate for somebody who continues their maintenance drug. So I'm sure the dose has something to do with that, and the thinking that, maybe I'm coming off of my drug.
That's the thing. I think that's probably because if you think how effective like cognitive behavioral therapy can be, even without medication, the opposite's also. If your thought, you start getting the fear and anxiety of like, oh my gosh, am I starting to get my symptoms back and I'm not on my drug anymore? That's gotta not be.
And that's for people who agreed to enroll.
Yeah.
So they must have been at least somewhat gung-ho about coming off their drug.
So that's, I don't know. I feel like that definitely had to have played a factor.
I will say that I remember reading in the supplemental data that they found that most patients that were on the placebo were able to guess. They screened the ones that were on placebo about guessing at the end of the completion of the trial, were they on the maintenance or placebo? And they had an overwhelming majority that guessed correctly that they were on the placebo. So
it's like, I feel horrible, so probably on the placebo.
Right.
That's interesting.
That's very cool. I didn't realize they did stuff like that.
Yeah. Supplemental data, it's so important. It's key.
It's key, man.
Good job, Trevor.
That's what I'm here for, baby.
So glad you saved it at the end, dude. Thought for sure you were coming back to see me next month.
Brought it all together.
All right. So thank you guys for listening. And I hope you guys are, enjoying the multiple camera angles and all that stuff. If you haven't seen the YouTube version of our podcast, make sure you check that out. We're going to hopefully next step add some live action while we're doing that as well. Maybe take calls, things like that, as if someone's actually going to take the time to call. It's wishful thinking. That's fine. We'll get 0 calls. AJ, tell your friends to call. And AJ will call from back there in the room. But thank you guys so much for sticking with us, and especially while Cole's microphone's so crappy today. But we really appreciate it. If you have any questions, comments, concerns, whatever, make sure you send us an email, and we will do our absolute best to get in touch with you. We've been getting a lot of messages lately, so I think I answered like 40 messages on LinkedIn the other day, and I was very proud of myself. And then I realized I had a whole bunch more in my email. I was like, never mind, I give up.
It's like a C-list celebrity kind of number right there, right? I don't know about that.
Thank you.
C+.
C plus maybe?
No,
he's got a bad rep with the pluses.
What's below D? Is there an E list celebrity where like 6 people know who you are because they live in your neighborhood? Sorry guys. Thank you so much for listening. Make sure you check out Pearls, and also Derek from Pearls. Thank you guys. Thank you so much for sponsoring the podcast. We really appreciate the support. Make sure you check out our Patreon. If you want to get into contact with us via text message, text 415-943-6116. And we'll see you guys in the next episode. Have a great one.